The 2025 ESC EAS Dyslipidemia Guidelines by Dr. Sina Rafat replace the previous 2019 framework with new predictive models and universal screening mandates. The 2019 SCORE model estimated 10-year fatal event risk for patients aged 40 to 70. The new SCORE 2 models expand this significantly. By capturing total disease burden, including non-fatal events like heart attacks and strokes, they prevent underestimating risk in women and younger patients. This bar chart comparing two 50-year-old men shows how regional data changes a patient's profile. The guidelines expand age coverage up to 89 and recalibrate risk across 4 distinct European regions. Under this system, a man in a very high-risk region has a 2.4 times higher risk of disease than a man exactly his age in a low-risk region. Risk assessment now utilizes a comprehensive mapping of a patient's total disease burden from age 40 through age 89. This top right section illustrates the transition to non-HDL cholesterol as the primary clinical indicator. It captures all plaque-building apolipoprotein B containing particles. Furthermore, in high triglyceride states above 150 milligrams per deciliter, standard LDL calculations become inaccurate, making non-HDL a mandated, reliable metric. This metric also exposes residual risk, identifying patients who reached LDL targets on statins but still harbor persistent plaque-forming particles that standard tests miss. Switching to non-HDL provides the biological data needed to reveal destructive particles in metabolically complex patients that standard calculations fail to detect. Looking at the lipoprotein A testing row, the old standard only recommended checking selected high-risk patients. The new 2025 standard is a Class 1 recommendation, universal one-time screening for LPA in every adult. LPA is entirely genetically determined. It is not affected by diet or exercise, requires no fasting for a blood draw, and is stable enough to only require a single measurement in a patient's lifetime. This sidebar defines genetic thresholds. LPA of 50 milligrams per deciliter increases cardiovascular risk 1.4-fold. 100 doubles risk. The critical 180 threshold confers 4-fold risk, equivalent to familial hypercholesterolemia. This hereditary risk means 50% of first-degree relatives share it, triggering immediate family cascade testing. Universal genetic screening removes the blind spots of lifestyle-only assessments, allowing for clinical intervention years before a patient's first cardiovascular event. This central graphic shows the expansion of the risk categories. The guidelines have moved from 4 tiers to 5, adding a new highest level, the extreme risk category. This tier identifies patients suffering recurrent cardiovascular events, such as a second heart attack, while they are already on maximum doses of statins and ezetimibe. The bottom right bar graphs show descending lipid targets. High-risk patients drop LDL below 70 milligrams per deciliter and very high risk below 55. For the extreme risk tier, physicians must drive LDL below 40 and non-HDL below 70 to stop arterial disease progression. This tier recognizes that some patients have a biological resistance to standard treatments and establishes ultra-low targets designed to force the regression of atherosclerosis. The 2019 method was sequential, starting a statin and waiting 3 months to see if more medication was needed. The 2025 philosophy replaces that delay. This flowchart shows the strike early and strong standard. High and very high-risk patients now start immediate combination therapy, receiving statins and ezetimibe together from day 1. Reaching targets as low as 20 milligrams per deciliter requires tools beyond statins. The guidelines now include bempedoic acid, PCSK9 inhibitors, and inclisiran. For extreme risk, triple therapy is deployed early. Physicians add biologics immediately if targets aren't met, removing the 3 to 6 month observation period. The 2025 guidelines shift from a delayed observation model to a protocol of immediate multi-drug intervention to prevent